Hi students, in this section on functional anatomy of the temporomandibular joint, we will be discussing in-depth mandibular movements, which is one of the most feared topics amongst students. Now, it is not as difficult as it seems, and most of you get a little intimidated with the border movements, diagrams, and the images, especially of the mandibular movements in three different planes, and that's what confuses a lot of students. So, we will discuss the different mandibular movements in different planes and understand that as a whole entity. Now, this is called Possel's envelope of motion, and to understand that, we need to know that mandible is a very special kind of a bone when it comes to your head and neck region. Now, the reason why I say so is because it is the only movable joint in the head neck face area, and the temporomandibular joint is the only movable joint. So let's recap a little bit of the fundamental of the temporomandibular joint. Now here in the first image, as you can see, we have the temporomandibular joint cross section. This is the condyle. This is the articular disc. This is the retrodiscal tissue. This is the superior joint cavity. This is the inferior joint cavity. And these are your lateral pterygoid muscles. Right? The superior and inferior parts. Now, when you cut the condyle into two parts, the part towards the midline is the medial pole, the part away is the lateral pole. So, medial and lateral pole of the condyle is something that we must know. Now, there are two kinds of movements possible in the mandible. The first is called rotation. The second is called translation. This is a ginglymus kind of joint, and this is arthroidal kind of a joint, and a combination of these two occurs as a resultant movement. So now when you look at the image here, you will see that in this cross section, in this image, in the horizontal axis, this is the horizontal axis, you see that a plane of rotation passes from the condyle on one side to the condyle on the other side. This axis of rotation is called the terminal hinge axis, okay, along which the mandible rotates. Now, after a first few millimeters of rotation, there is a bodily movement or translation of the mandible. So, there is a combination of these two movements. That means it is not purely rotational or purely translational. It is a combination of these two. Okay, this has to be very clearly understood that the mandible rotates first and then translates in the resultant movement. So, what are the movements? You can open your mouth, you can close your mouth, you can protrude your jaw, but can you actually retrude? So, if you try to retrude, you will realize that only a very little possibility exists of retruding, right? So, when you have your teeth in your maximum intercuspation, that means close your teeth, maxillary and mandibular, against each other and bite on them and try to take your jaw backwards. There is a very little possibility of being able to take it at the back. Now, this most retruded position, which is not related to the tooth, independent of tooth contact, is called centric relation. Okay, centric relation is an important position of the mandible which needs to be understood. So it is a maxillo-mandibular relation. That means relation of the mandible to the maxilla, independent of tooth contact. It does not depend on presence, absence, or contact of teeth. It is a skeletal, purely skeletal or bone-to-bone position. Okay. in which the condyles articulate in the anterior-superior position against the posterior slopes of the articular eminence. Now, what is the articular eminence? So, this part, this is the fossa, and then there is this eminent part. This is the articular eminence. Okay, do you see this dark portion in this image? That is the articular eminence. Now the condyle fits here technically. This is the medial pole, this is the lateral pole. The medial pole is the one through which the hinge axis passes. So the medial pole on one side connects to the medial pole on the other side with the help of this axis. This pole has to be positioned in anterior superior. This is the superior most and the anterior most portion in the articular eminence. On the posterior slope, this is the posterior slope of articular eminence, this is the anterior slope. Let me show you the articular eminence in another diagram. See, this is the articular eminence. This is the medial pole where the condyle will have the medial pole here. So this is your medial pole and this is your lateral pole, articular eminence, right? This is the posterior slope, this is the anterior slope. So here the condyle is located in superior and anterior direction with regards to the articular eminence. In this position, the mandible is restricted in a purely rotary movement, right? In this position, only a rotary movement is possible and translational movement is not possible. This happens only after a little bit of rotation. From this unstrained, that means it is an equilibrium state position. There is no muscle contraction or relaxation. They are in tonic equilibrium. From this unstrained physiologic relationship, the patient can make vertical, lateral or protrusive movements and it is clinically useful and a repeatable reference position. The reason why we always choose to rehabilitate the patient's dentition or denture or full mouth rehabilitation in centric is because it is the most repeatable reference position, right? So you can always have a starting point of the skeleton relationship. Now with this information in mind, let's try to work on this text. So the mandibular movement occurs as a complex series of interrelated three-dimensional network or three-dimensional rotational and translational activities. So there is rotation and translation. It is determined by combined and simultaneous activities of both temporomandibular joints on the right and left side. So the two type of movements are rotational and translational. The rotational movement occurs as a movement within the inferior cavity. Now what does that mean? So coming back to this image, this is the medial pole, this is the lateral pole, okay? This is your inferior cavity. This is your superior cavity. So rotation occurs in the inferior joint cavity. Translation occurs in the superior joint cavity. That means the condyle will rotate only in this area. But when it comes to bodily movement, it shifts the articular disc. So when the jaw moves forward, the disc moves backwards. Remember, we had discussed this in the previous video when we were talking about the articular disc. The articular disc moves backwards, so the retrodiscal tissue will push the articular disc backwards as the condyle or the jaw moves forward. So the superior region or the superior cavity relates to translation, the inferior cavity relates to rotation. Okay, next. It is thus the movement between the superior surface of the condyle and the inferior surface of the articular disc. The superior surface of the condyle, this is the condyle and this is the articular disc. So the inferior surface of the disc and superior surface of the condyle. This is where rotation occurs. Now this is an example of rotational movement. It starts at a fixed point. So you need a fulcrum or an axis, which is called the terminal hinge axis. Now move on to the next page and you will find these three images. Okay. Now these are the different rotational axes. We have spoken about this axis. This is called the horizontal axis, which is the terminal hinge axis position, THA. The short form is also acceptable. So in this kind of question, if you read the word THA, it refers to terminal hinge axis. So we are talking about the rotational axis first. Now in this, the mandibular movement occurs around the horizontal axis. This is an opening and closing motion referred to as the hinge movement, like a door hinge. Okay, this allows opening and closing kind of movements. So you can close your mouth and open it with the help of this movement. And the horizontal axis around this is known as the hinge axis. When the condyles are in their most superior position, we spoke about the superior position when we spoke of the centric relation. Here in the articular fossa and the mouth is purely rotated option. The axis around this is called the terminal hinge axis. Now, what is the difference between hinge axis and terminal hinge axis? Terminal is in the superior most position. That means when the condyle is in its most superior position, at that time, if it rotates, then the axis of rotation is called terminal hinge axis. But if it is not in its most superior position, and if there is a rotational movement, then it is just called a hinge axis. Then moving on to the next plane, which is the frontal plane or the vertical plane. This is frontal or vertical axis. Now, does the condyle rotate like this along one side? Can you just rotate one condyle and the other does not move? It is not possible. Even in the sagittal axis, this is sagittal axis. This pure sagittal movement only in one condyle is not possible. It has to be two sides simultaneously. So, this is because of the inclination of the articular eminence, right? Because you have the articular eminence in this area, it does not allow the condyle to rotate single-handedly in that area. Okay, and this is why this isolated movement does not occur naturally. And in the sagittal, that means in this section, because it is suspended by ligaments, there are ligament attachments on all sides. It does not allow the musculature. The musculature will not allow the condyle to get displaced in the inferior segment. That means it will not allow the condyle to just hang. It's like a sling. It does not allow it to fall down because it is suspended by ligaments. So these two movements are of no relevance when we talk of mandibular movements. The most important is the horizontal or the terminal hinge axis movement. Then heading on to the translational movement. In the masticatory system, it occurs when the mandible moves forward. For example, when you are protruding your jaw, and the teeth, condyle, the rami, all of them move forward in the same direction and in the same degree. You remember translation in physics when we talk of displacement of a body from one place to the other entirely. So all the parts of that body are moving in the same velocity. If you remember from your physics, okay. So the teeth, condyle, the whole assembly, they all move in the same direction at the same degree. That is known as translation. Now, translation occurs in the superior joint cavity. Like I told you, here translation occurs in the superior joint cavity. Between the superior surface of the articular disc and the inferior surface of the articular fossa. Right? Superior surface of the disc and inferior surface of the fossa. So that is translational movement of mandible. Now moving on to the part that is usually most intimidating to students, and that is the border movements of mandible. As the name suggests, we are talking about the boundary movements of mandible. So if I open my jaw wide open, like if I open the jaw mandible completely, that is a border movement. Let's look at this diagram. Very easy to understand, okay? So I just want you to see the mandibular movements from different angles. We are talking about a three-dimensional view, right? So this first one is from a sagittal view. That means taking a mid cross section along the midline and seeing that from the side. So seeing someone from the side with a camera is the sagittal view. Sagittal view is called the side view. The next view is called the horizontal plane, the horizontal view. That means from the top. So if I see someone, if you section the head at the level of mandible and see something from the top, you'll be able to see the mandible like this. And then the third view is called the frontal view, or the vertical view, which is from the front. Right? If you see the mandibular movement from the front, you will be able to see this kind of a movement. Now each of them are accompanied by a small image which you can see underneath. The first image is a beak shaped, a parrot beak shaped image. The second is a rhombus. Third is a shield. This is the kind of shield that the warriors used in older days, and with a sword in one hand and the shield in the other. Now, what is the significance of these images? These are known as border movements. So, if the mandible goes right, it will appear as an arrow on the right. So, if I am seeing this from the top view, horizontal view, left and then protrusion, right and then protrusion. So, whatever view of the mandible, if the mandible is moving right, then you will see a tracing in the right, in that specific plane. These are known as border movements of the mandible. Now, let's look at the first single plane border movements. What does this say? It says that when the mandible moves through the outer range of motion, so borders of the mandible moving in all three planes is called the border movements. Okay, and we will be talking about each specific section in detail. So this is in the sagittal first, right? Sagittal, plane, border and functional movements. This is the beak shape tracing that I told you. Now how do you interpret this tracing? So this number 1 corresponds to this number 1. This number 2 corresponds to this number 2. 3 and 3 and 4 and 4. Okay. Now what does 1 say? It says posterior opening border. So if your teeth are in contact over here, intercuspal position, ICP, that means your teeth are in maximum intercuspation. This is posterior, this is anterior, right? So posterior opening border, that means if you open the mandible, like that. So it happens in two parts. The first part is rotational movement of the condyle. The second part, B, is the translation. Okay. So opening of the mandible occurs in two parts, rotation first and then translation. How much rotation? So for the first 20 to 25 millimeters of mouth opening, the condyles will have a terminal hinge or rotational movement in that segment. And then as you open your mouth wider, it is going to be translated. So this is translation on further mouth opening. This is number 1. Then anterior opening border. In the front, when you protrude your jaw and open, then there is only one single translational view, translational border movement. There is no rotation involved. Superior contact border is this segment, which we are going to discuss in a little bit detail. So we will understand what is happening over here. But for that, first, CR or centric relation is the posterior most position of the condyle. So how do you correlate that in your mouth? First of all, close your teeth in their maximum intercuspation, and then try to retrude your jaw a little bit behind. You will be able to feel that there is some movement possible. So if suppose this is your centric relation, this is your maximum intercuspation or ICP, you can retrude your jaw a little bit behind, right? If this is your CR, then this is your ICP, right? This is the retrusion shown in the image. Now try to move forward. So when you take your jaw forward, your incisors will start hitting each other because of the lingual slopes of the upper and because of the incisal edge of the lower. Centric, ICP, and then there is some ditch when your teeth contact each other. Okay. After that, your teeth come edge to edge. So this line indicates the edge to edge movement of your teeth. After that, if you have to take your jaw further forward, you will have to cross it and go ahead. Right? So this is that protrusion. And then if you open your mouth, this is what you will receive. The line over here. Got it? So in one plane, in the sagittal x, just keep in mind that everything is happening in a sagittal position. That means you have to view from this position. So first centric, then intercuspation, right? Then getting your teeth edge to edge, and then hitting, and then protruding, and then opening your mouth. Got it? So this is how it looks. Make sense? Now, in a head upright position, that means if you are sitting up straight, this is how the beak will look. This is how the tracing will look in an upward position. But if your head is extended behind at a 45-degree angle, then the tracing will appear a little different. Even when you are head down position at a 30-degree angle, the tracing will appear different. Now, what is the difference? If you look at this portion, there is this one line which is posterior here and which is anterior here in comparison to the ICP, right? So if you have your head behind, if your head is raised 45 degrees behind the postural position, your normal position, then the teeth will occlude and the teeth contacts occur posterior to the intercuspal position. This line is posterior to the intercuspal position. See, the line is here. This is ICP, right? So if your head is tilted up, the tooth contacts will be behind, posterior to the intercuspal position. On the other hand, if it is head down, it will be anterior. Now the question arises that normally in any rehabilitation, you want to rehabilitate in centric relation. That means for complete dentures, say for example, whenever you make a jaw relation, you record the centric and then arrange the teeth. So here, centric relation and intercuspal position are same because the occlusion of the denture is made in centric relation, which is known as centric occlusion. So here, the border movement will be a little different. There is one common point joining these two, which is CR is equal to ICP. So this happens in CD. This is in a normal dentate patient. Got it? Then the last part is typical functional movement. So if you look at this teardrop number 4, this is the functional movement. Normally when you are eating, chewing, talking, you are not going to open your mouth so wide in an exaggerated form. The functional movement of the mandible is limited inside this. So that is the functional stroke. That means only this much is the normal movement that happens when you look at the cross section from the side. Right? So this again anterior closing border is the number 2, and this is what we already discussed, number 3, and this is your number 4. So that is your chewing stroke or functional border movement in sagittal plane. Now likewise, we have to visualize this in the horizontal plane and in the frontal plane. So this is horizontal plane, that means looking at the jaw from the top. So there are four things to see: left lateral border, and then continued left lateral, right lateral, and continued right lateral with protrusion. To understand this better, let's take a look at this image over here. Now, if you want to move your jaw on one side, say the left side, okay? So left is your working side and right becomes your balancing side, also known as non-working side. Easy? Now, on the left side, the condyle is going to rotate in its position. But on the right side, this is called the orbiting condyle, is going to shift from its position. So, rotating condyle is on the working side, orbiting condyle is on the balancing or the non-working side. Now, based on this understanding, let's start our centric. So, when your jaws are in centric relation, there is a little retrusion possible from intercuspal position to centric. So, this line now from intercuspal position to centric and then move left. So as you move your jaw on the left side, this is the kind of tracing you will see from the top. And then you open your mouth. Same thing on the right, and then you open your mouth. This same thing is in the blanks below. But to understand this with a diagrammatic image, so this is your left, left, right, and right. Now this is left lateral. That means you are moving your jaw on the left side. So this is rotating and this is shifting. This is the working side, this is the balancing side. Correct? So this angle, this movement is the left lateral. Likewise, this is the right lateral. So this is your orbiting condyle and this is your balancing. Sorry, this is your rotating condyle and this is your orbiting condyle. Right? And these two arrows below is related to protrusion. So move your jaw on the left and then protrude, and move your jaw on the right and then protrude. So these are the kind of movements that you will visualize from the top in the horizontal plane. And the functional movement are also similar to that you will see in the sagittal plane. So the actual functional movement is very little when you compare to the whole border movements, right? Centric relation is demarcated, then the intercuspal position is demarcated, and then you have the end to end position where the teeth come edge to edge, right? So this is how your borders will appear in horizontal plane. And then lastly, the third plane is the frontal plane or the vertical border movements, which is the easiest. It gives you a shield shaped tracing. The same information fills here. Now, starting from your intercuspal position, you will see there is a little difference between centric and intercuspal position. If you take your jaw on the right and left, you will get these kind of borders followed by protrusion or opening borders. That means start your jaw movement on the left, so you get this. Then you open your jaw from the leftmost position, so you get this angle, this border. Then continue on the right side same way, so you get this border, and then open from the rightmost position, so you get the opening border on the right side. With this understanding, you can three-dimensionally visualize the movement of the mandible. Why is it necessary? So that you can do all your restorations keeping in mind these border movements and then adjust the occlusion according to the requirements. You have to incorporate teeth in these movements. You don't have to incorporate these movements in your teeth, right? Now, a few factual things to remember. The muscles of mastication are at the lowest level of activity when the mandible is positioned 8 mm inferior and 3 millimeter anterior to the maximum intercuspal position. These are some facts to remember, okay? Point number 2, dash records mandibular movement in horizontal plane. The answer is Gothic arch tracer. Remember, in centric relation, we get an arrowhead tracing like this. So all that visualization is in this plane. You get from centric relation to protrusion point to left lateral and right lateral. Okay. So this is your arrowhead tracing. Now that occurs in horizontal plane movements. In this technique, what is attached to the maxillary teeth? So you have a plate, central bearing plate, which is attached to the maxillary teeth, and you have a stylus attached to your mandibular teeth. Now the shape of border movements, as we discussed, sagittal is beak shaped, horizontal is rhomboid, and frontal is shield shaped. Together they comprise Posselt's envelope of motion. This together, all of them, they create a three-dimensional area in which you can actually visualize the 3D maximum range of movement of the mandible, that is known as Posselt's envelope of motion. What is optimal functional occlusion? So there are 5 criterias which help you understand that the occlusion of a patient is most stable or least pathogenic when the following features are met. So in order to understand this, we have to understand a little bit of the temporomandibular joint also. So this is because of the orthopedic stability that the occlusion is also stable. When the mouth closes, the condyles are in the most superior anterior position, or which is a musculoskeletally stable position, resting against the posterior slopes of the articular eminence, which we discussed with the centric relation definition. In this position, there is even a simultaneous contact of all posterior teeth. The anterior teeth also contact, but more likely than your posterior teeth. So understand, keep your teeth in maximum intercuspation, okay? And right now, it is a little away from your centric position, right? We saw that centric and maximum intercuspation are a little away from each other. But when the joint is in centric relation at this time, there is a very little contact on the anterior teeth, and your posterior teeth are in complete contact. Can you feel it yourself? Your posterior teeth in full contact, anterior teeth are just slightly touching, right? All tooth contact provide dash, that is axial loading of occlusal forces. Okay, first of all, understand this. So your joint, this is the most posterior position, and we are talking about the most stable position, the solid line where your joint, the mesial pole, is against the superior and inferior slope of the articular eminence. So you can still take your joint a little behind from centric relation to intercuspation, but it still remains the superior most position, right? So the condyle will still be in the more superior position, and that is why it is a stable position of the jaw. When the mandible moves into laterotrusive positions, there are adequate tooth-guided contacts on the working side and to disocclude the mediotrusive non-working side immediately. The most desirable guidance is provided by canines. This is known as canine guidance. Okay, what does this mean? Take your jaw on the right side. You will realize that your canine is touching on the right side, and your posterior teeth may or may not be touching, but your left side, the teeth are not touching. This is provided you have completely natural dentition. So, when you move your jaw on either side, and if the canine is touching only and the posterior teeth are not touching, it is known as canine guidance. If your teeth are touching multiple, like if you have all posterior teeth or a few posterior teeth touching, this is known as group function. As you can see, this is canine guidance, this is group function. This is happening on the side of jaw movement, okay, on the laterotrusive side. But on the other side, On the non-working side, there is no tooth contact. This is a sign of a healthy occlusion. Then when the mandible moves in a protrusive position, there are adequate tooth-guided contacts on the anterior teeth to disocclude all posterior teeth. Now bring your anterior teeth edge to edge like this. Okay, you will realize that anterior teeth are contacting and posterior teeth are not contacting. These gaps at the back is known as Christensen's phenomenon. Okay, Christensen's phenomenon is a part of dentulous patients, indentate patients. Now, this property where in maximum intercuspation the posterior teeth are in contact and in protrusion the anterior teeth are in contact is called mutually protected occlusion. That means the anterior teeth are saving the posterior teeth from excessive forces in protrusion, and the posterior teeth are saving the anterior teeth from maximum forces in maximum intercuspation. This is known as mutually protected occlusion. Okay. In the upright head position and alert feeding position, the posterior teeth contacts are heavier than anterior teeth contacts. So when you are very alert, you will have stronger posterior teeth contacts as compared to anterior teeth contacts. And now moving towards the later part of this video where we will talk about Bennett movement and Bennett angle. So for that, again coming back to this specific presentation of the jaw in the horizontal plane, rotational condyle on one side and orbiting condyle on the other side. Okay. Now, what happens on the orbiting condyle? So suppose if you move your jaw on the right side, then the left side condyle is shifting. If you move your jaw on the left side, then your right side condyle is shifting. This lateral shift of the non-working or the balancing condyle is known as Bennett movement. Means, supposing this is where your condyle is located. Okay, this is your medial pole, this is your lateral pole. We are talking about the rotation and everything of the medial pole. So because there is this, suppose if this is your non-working side, then if you move your jaw on that side, there is a shift of your condyle in this plane on the other side, towards the other side, towards the working side. This movement is known as Bennett movement. Now, it is classified into three parts: immediate side shift, recurrent side shift, and progressive side shift. We will talk about that in the text. And something else known as Bennett angle. Now, what is Bennett angle? So, Bennett angle is nothing but the angle formed by the sagittal plane and the path of advancing condyle. So, this is the original position of your condyle. This is the rotating condyle. This is the working side. This is the balancing side. Okay, so this is the original plane of the condyle, and this is after the movement. So the crossover of this is called the Bennett angle. Now this is important because this value has to be adjusted in your semi-adjustable articulator so that you can customize the articulator according to the patient's values and minimize all the lateral errors in occlusion, because you are already making sure that whatever the patient is doing in the mouth is taken care of on the articulator. So this is known as Bennett angle. Okay, so let's go through the text now. Bennett movement is nothing but the lateral movement or the lateral shift of the mandible resulting from the movement of the condyle along the lateral inclines of the mandibular fossa in lateral jaw movement. So this is your working side, this is your balancing side. So this happens on the balancing side where there is a shift of the condyle from one side to the other. It is the bodily side shift which may be recorded in the region of the translating condyle of the non-working side. Translating means orbiting condyle or balancing condyle. During the lateral movement, the mandible shifts as a whole by around 1 to 4 millimeters towards the working side. This shift is called as Bennett movement and not associated with lateral protrusion and may occur or along with lateral protrusion. It can occur with any lateral movements. Now, three classifications, three types of this that you just need to know. Immediate side shift that occurs before the forward movement of the non-working condyle. So, before the condyle actually moves forward, immediate side shift will occur. Precurrent side shift occurs as the major part of the movement, and this is nearly 2 to 3 millimeters after the movement of the forward movement of the non-working condyle. And lastly, it's called the progressive side shift, which continues to occur after the forward movement. This is the lateral translation that continues linearly after the 2 to 3 millimeters of forward movement of the non-working condyle. We are talking about the non-working condyle only. Okay, non-working condyle is associated with Bennett movement. And Bennett angle is the angle formed by the sagittal plane and the path of advancing condyle during the lateral movement as viewed in the horizontal plane. So when you see it from the horizontal plane, the angle formed between the original path versus the advancing path. Okay, this is the angle formed between the path of the non-working condyle and the sagittal plane. Average value is 7.5 to 12.8 degrees, and you have to adjust it in the articulators with lateral translation capabilities so that you can customize the articulator exactly as per the patient readings. Bennett angle can be measured with the value with the formula h by 8 plus 12. We will talk about this in balanced occlusion, so make sure you watch that video where h is the horizontal condylar guidance and it will give you the Bennett angle. So you get this value of h from Gothic arch tracing. You take a protrusive record and then you get the L value with this formula. So for now, just remember the formula h by 8 plus 12 and watch the video on balanced occlusion to understand how this formula actually works. So h is nothing but the horizontal condylar guidance, right? And this angle is nothing but the Bennett angle. So this I know was a very long video and you have a lot of things to keep in mind. But what kind of questions to expect? You can have direct image based questions as to what is this point on a given border movement of mandible. So you could be given any of the border movements and which point is marked. You have to identify that. Second kind of questions would be Bennett angle and Bennett movement. Which condyle? So it's the non-working condyle. You have to remember the values of the movement and the angle. And then you have to, in general, understand the mechanics of the temporomandibular joint and apply that in rehabilitation. Okay, so I hope this solves a lot of your doubts. For more understanding on how to solve these questions, make sure you watch the videos which are attached to the questions. And if you still have any doubts, we are here for you. Thank you so much for watching and good luck.